All right. Well, thanks everyone for joining today. I'm going to be chatting on the recent paper that came out on molidustat and the use in anemia with cats with chronic kidney disease. This is a follow-up from, I believe Dr. Finstad had discussed two of the previous papers here. I'm going to be piggybacking off of some of that. When we look at, and sorry, I can't really tell. Can everybody see my slides?
Yes, you can.
Okay, perfect. Thanks. So when we look at EPO production, these are generated by these special interstitial cells within the kidney called pericytes. Really concentration of hemoglobin. When it decreases, these pericytes are sensing hypoxia and ultimately transcribe and produce erythropoietin. This transcription is increased under hypoxic stress, and ultimately this erythropoietin is released into circulation, binds to the EPO receptor on erythroid progenitor cells, and this prevents these progenitor cells from undergoing apoptosis and release these immature red blood cells. In the normal setting, when the kidney senses hypoxia,
I'm so sorry, Dan. I said that we can. I'm still seeing the first slide. I don't know if you're advancing. Maybe others are seeing it
oh,
correctly, but I still see the title slide. I'm sorry.
Yeah, I have the same, Bianca.
interesting. Let me see what the sharing looks like. Hmm. Good questions.
It
Desktop.
looks like it may be frozen if you just refresh it.
Did that work?
Yep.
Okay. Um, okay. So in the normal kidney, when there is regional hypoxia, these pericytes produce EPO by binding this HIF2 alpha with this HIF beta and forms this complex that ends up transcribing, leads to the transcription of EPO at the cellular level. This ultimately will drive the process that we discussed on the previous slide. When we are transitioning into patients with chronic kidney disease, these pericytes undergo some myofibroblast transition or transdifferentiation, where the extracellular matrix expands and deposits, leading to fibrosis in this region of the kidney. And so when we are in that chronic disease process, unfortunately, these myofibroblasts undergo this epigenetic change where there's no longer there's silencing of the DNA, and essentially the HIF complex cannot bind and transcribe EPO. When what happens at the cellular level, it really is kind of dictated by in patients with hypoxia, this PHD inhibitor it becomes activated and essentially has some hydroxylating properties that basically ligates all these factors here that ultimately drive the transcription of EPO. I won't go into the nitty-gritty of transcription there, but that's essentially what is happening at the cellular level. The Did that advance?
It did. We can see your speaker notes, but we can still see it.
Interesting. Boy, the Google is not very friendly, is it? As a platform. This is the first time that I've used it through Zoom, so I am not quite sure what's happening there. So the HIF pH inhibitors, this is the hypoxia-inducible factor prolyl hydroxylase inhibitors. This is a class of drugs that has been utilized in people with chronic kidney disease that have anemia. Remember, as we talked about previously, that the HIF2 is really the key transcription regulator of EPO production. So when these HIF PHIs are administered, we get an increase in expression of HIF2 in the kidneys and the liver, which increases EPO production that increases the bone marrow response, increasing iron demand, not only in the bone marrow, but also this HIF2 also will increase the movement of iron from its stores in the body through this ferroprotein, which ultimately binds to this iron binds to this transferrin protein that goes to the liver, also goes to the bone marrow to mobilize iron throughout the body. The ferroprotein receptor is regulated by hepcidin, and so in situations where we have too much iron stores, this will be downregulated. To look at veterinary medicine, we've got two kind of initial studies that Dr. Finstad had chatted about previously, and I'll just kind of highlight what she had already discussed in those previous journal clubs. So the first study was looking at a pilot study in a population of 17 cats, looking at molidustat on erythropoiesis in healthy cats. There was really three groups in this data set. You can see that the placebo group indicated by the triangles versus the 5 mg per kg group in the circles and the 10 mg per kg group of the molidustat was the rectangles or the squares. And you can see that there was a significant jump in hematocrit in these healthy cats that were both in the 5 mg per kg group and the 10 mg per kg group. There was early cessation of the treatment phase at day 12 in group 3 and day 23 in groups 1 and 2, rather than going out to the 56-day trial there. And you can see that the erythropoietin concentrations had spiked within that first 6 hours in both the 5 mg per kg and 10 mg per kg group. So we do know that there is some efficacy in healthy cats, and we saw a significant change in the group there. To piggyback off that study, they followed up with a second study in the sample or the treatment category that we're all interested in chronic kidney disease and anemia in these cats. there's in this patient population, there were 15 cats in the molidustat group. There were 6 control cats. And looking at the hematocrit data in this study, you can see that the molidustat group had a significant increase in their hematocrit at that 21-day mark compared to the placebo group. It's kind of interesting that the placebo group did drop, and we're comparing one group that is increasing versus one that is not necessarily getting the drug that is dropping. So, is it truly significantly different between the two groups? It would say so on paper, but I guess if you got a decreasing population in one group, how much significance are we actually seeing? And when we go back to some of the guidelines that we all, practice by, with IRIS stating that our PCV should be close to roughly 30%. Even in this population, we really never got close to that 30% range. And so, that's where I think the next study is, beneficial. And okay, what do we do with these cats after that first 20-day mark? And I think that we've all probably struggled with that in the last couple of years per se. Looking at the mean PCV in these cats, and they did kind of a mini continuation phase in this first study, where if you look at the PCV data in these cats on a weekly basis, there wasn't much change after that 35-day mark. Kind of was pretty flat in this range. And so do we reach kind of a ceiling at which this is an efficacious medication? Those are all kind of questions that we're hoping to get answered with this next study. So that leads us to the study that just came out, based looking at the effectiveness of the long-term safety and repeated oral administration of molidustat in the management of anemia associated with chronic kidney disease in cats. And so this was a multi-center, randomized, double-masked, placebo-controlled study. Initially, 75% of the cats that were enrolled in this study were client-owned, 75 total, sorry, not percent, with CKD and in the effective safety phase, which was up to 28 days. They then continued it through 20 weeks, so about 6 months total, to determine what the safety data looked like. Was there any change in these cats in the long-term data? And so when they look at treatment success, they're defining that as a greater than or equal to 4% increase in their hematocrit compared to baseline, and or a 25% increase in hematocrit on the study time frame between the 28 days and 0 days. When we look at their inclusion criteria, it's similar to the previous studies where the patients had to be greater than or equal to 1 year of age, greater than or equal to 2 kilograms. Their anemia was defined as a PCV of less than 28%. And their historical CKD data was present, and they defined it with a creatinine of greater than 1.8. So essentially stage 2 and beyond. After the effectiveness and safety phase, which was that first 28 days, they ended up opening this up to an unmasked open label study for an additional 20 weeks, or a total of 6 months. And they they controlled their population via a negative FeLV, FIV test, urine cultures that were negative, and systolic blood pressures of less than 165 millimeters of mercury. There was some heterogeneity in this population. They allowed fluids, permissible medications, including monthly preventatives, what they called CKD support, antihypertensive medications, phosphate binders, iron, so on and so forth. The comorbidities that these patients had, they needed to be stable for a minimum of 2 weeks. Now, I think that there are quite a lot of variations, especially with our GI cats. And are they ever stable? Question mark. Versus those with hyperthyroidism, they needed to, have a greater than or equal to 6-month stability with their disease. When we look at their treatments and primary hematological variables, the molidustat was dosed at a 5 mg per kg dose, similar to the previous study, and the control was given at the same volume with the dosing syringe. If you look at their flow chart here, they discontinued treatment in cats that had a PCV or hematocrit of greater than 45%, or their hematocrit had a greater than 20% decrease from the start of the study to day 28. If their hematocrit was greater than or equal to 28% on day 28, or they had a less than or equal to less than 28% hematocrit on day 28, they moved on to the continuation phase. This continuation phase looked at that following 28-day cycle where they had a 7-day intermission, which they ended up transitioning to this continuation. All these cats received molidustat if their PCV was less than 28% at the completion of that first cycle. The treatment administered in the 28-day cycles for up to a possible 4 additional cycles. So up to 5 cycles, as we talked about, up to 6 months total. They still had that same criteria where if their PCV was greater than 45%, then they stopped or they were excluded for further treatment. In addition, the patients that had a greater than 20% decrease in their hematocrit. I struggled with this paper because they kept on going between hematocrit and PCV, and we know that they're not the same. So I was very much struggling with that. But their figures both say PCV and hematocrit, and I know that they did show some variation in some of their previous studies on their hematocrit and PCV assessment there, but I did find that as a slight nuance that was irking me. Their clinical visits, looking at the effectiveness and safety phase. So they came in on day 0, 7, 14, 21, and 28 for some lab work, mainly body weights and evaluation their hematological data. On their screening at day -7 and day 28, there was a chemistry and urine performed as well. There was also some owner assessments looking at quality of life and daily observation of the cats that were in this study. In the safety continuation phase, they had weekly visits on days 35 and 42, and then they went to biweekly up through the remainder of the study. In the safety and continuation phase, they looked at body weight, systemic blood pressures, and PCVs throughout their time. So, as far as outcome measures, their primary clinical endpoint for the effectiveness and safety phase, as we discussed, was that increase in hematocrit of greater than or equal to 4%. Overall 25% increase in hematocrit or combination thereof on day 28. Failure to reach that endpoint was if their hematocrit was at that 45% mark or had decreased by that 20, greater than or equal to 20% from the initial time point. Their quality of life was a subjective, try to make it as objective as possible, but subjective in regards to looking at their day 28 relative to baseline score. And then looking at any sort of adverse events, owners were observing their cats daily and jotting down any abnormal events. And then the site investigator would evaluate for any sort of potential relationship between the treatment versus progression of CKD versus underlying clinical disease process or comorbidity. So looking at their stats, they did have a power analysis where they determined a minimum of 45 cats were needed per group to find a statistical power of greater than 80% to reach a 20 to 30% success in a molidustat group. All these tests were two-sided with significance set at a p-value of less than 0.05. Their primary endpoints were in a linear mixed effects model. Their adverse events analyzed by a Fisher's exact test, and then their clinical pathological data and BP data were descriptive analysis. So when we look at their study cohort, they initially had 95 cats that were screened. They had to eliminate 20 cats based off of reasons that were either related to death or they had to discontinue their treatment due to various reasons or they're not meeting their inclusion criteria. So they had a 75 patient population mixed up between 40 in the molidustat and 35 patients in the placebo group. When we're looking for kind of their demographics, their pre-existing conditions, secondary or unrelated to CKD, there was hypertension in that group, heart murmurs, urinary tract infections, GI disorders, periodontal disease, osteoarthritis, pretty much all the diseases that we see in every cat that walks through our hospital. And so I think they definitely had a good representation of what it's like in the clinical setting. Their concomitant medication was administered in about 3/4 of the patients. And so once again, very representative of what we see in the clinic where they're either getting some electrolyte support, maybe on some antibiotics, ACE inhibitors were mentioned, anxiolytic medications, and they had a median iris stage of 3 in both the groups that were tested, both the control and the molidustat. So when we look at the results, looking at the molidustat group versus the placebo group, you can see that the molidustat group definitely had a significant change upwards at that 21-day mark and the 28-day mark. They had what they termed a 69% success rate at day 21 and a 67% success rate at day 28. they did have some attrition with some of these cats where they either died or euthanized within completing that study or within that 7 day kind of washout or intermission phase, which has definitely led to the question of how much progression is happening with these cats in this study. And when we look at some of the safety and continuation phase data, you can see that this is the first cycle, which showed that there was an increase in their PCV really across the board, upwards to that fourth cycle here. That fifth cycle is kind of interesting to see that they actually had a drop compared to the remaining cycles. But none of this was statistically significant, but we did see an upward trend of their PCV data that ultimately they never really reached a mean of 30%. So that target range that has been designated by IRIS as kind of our goal. But we do see that there is an upward trend within the first 4 cycles in the molidustat group. The cats, they either were if they reached a PCV of greater than that 45%, they were out of the study. If they had that 20% reduction, they were out of the study. So you can see that over the course of time, their numbers diminished. When you look back at the flow chart, they lost about 50% of their patients. They went from 64 down to about 30 total through that continuation phase. Ultimately left off with 10 cats at the end of that 6-month period there. So, I think what we can gather is, a number of these cats did show some improvement in their PCV data over the course of the 6-month time frame. We'll call it 5 months. Ultimately, we're not quite hitting those targets that IRIS has set up as guidelines for us. When we look at really the intermission phase or that transition phase, and each cat went through that through each cycle, and so they had a drop in PCV anywhere from 0.2% to 4.8 percentage points. And so that can be quite significant in a 7-day period if you're dropping by almost 5 percentage points with your PCV. And so, I think that kind of begs the question is, why do we need to have this intermission phase? Is that there was no specific reason other than it was like study protocol here. So I don't know if there's a safety concern related to that, but I do think that some of this data could have been affected by the fact that some of these patients are dropping by as much as 5 percentage points in that intermission time frame. So I thought that was an interesting point. But ultimately, we can see that their PCVs did slightly increase through that time frame. Their adverse events were not any different between the molidustat and the control group, and then long-term wise, they didn't find that to be significant between the groups, and even in the continuation phase. And then the comorbidities were pretty stable throughout. So that didn't really play a significant factor. I am curious about some of these remaining cats, that especially the ones that dropped. I think the question kind of boils down to me is, are these patients, do they have iron depletion in these cats with their chronic comorbidities potentially? Are they just more advanced with their chronic kidney disease and just not responding as effectively? So I definitely had some questions on that last group that ultimately, why they were dipping compared to the other groups. And so what we could see is these cats that are treated with the molidustat in the first 28 days did have a significantly higher hematocrit compared to the control group. This continuation phase upwards up to that 6-month time frame where they repeated their 28-day cycles did show an increase in their PCV in the first 4 cycles, not that 5th cycle. And so that's kind of where my question of what's happening with those cases in that particular group and why they're not responding. I think limitations for this study, they were comparing hematocrit versus PCV. They're not the same. And I guess to me, it could have been just easy enough just to do PCVs all throughout. If you're pulling blood for hematocrit, you can easily just do a PCV while you're there so that you're comparing apples to apples. They mentioned that they didn't monitor any sort of iron stores, and they were using different laboratories as this is a multi-center study, both in the US and the UK. And, ultimately, you're going to be using different labs, but I would imagine that some of the differences between the labs, could have been corrected by just getting a manual PCV count. And that would be less of a limitation for this study. So in conclusion, the molidustat, it did increase erythropoiesis in cats with chronic kidney disease. They did determine that even in the longer continuation phase that the EPO control mechanism is preserved in these cats. And so, I think it's an option for us to utilize this on a longer term basis. This kind of brought up some questions on kind of my own experience and what maybe some of your guys' experiences are. So now that we have more experience with this medication over the past couple of years, what are some of the impressions anecdotally? I personally have had a number of clients say that their cats are not eating as great on that medication, and do we see changes in body weight as a result of that? I always question whether this is progression of the underlying disease process or is this truly related to the molidustat itself. Brought up the question of that 7-day break or that intermission between the 28-day cycles, with the significant drops that we're seeing in this study. Does it beg the question of, do we actually need that drop or that intermission? And can we just continue these patients throughout without seeing the significant drops in these patients? And then also kind of a question that I have and I've used previously is, does anyone else use alternative long-term ESA protocols? So long-term darbepoetin on a every other to every 3-week basis, in lieu of these HIF stabilizers that may have some in some patients if they're not eating great or having some hyporexia, are we counteracting that by a different ESA in those patients? So that's all I've got. I didn't know if anyone had any follow-ups to my questions here.
Thanks, Dan. That was great. Really appreciate all the hard work to summarize what we know of it so far. It's funny. I just saw the appointment right before this one was a cat that was started on molidustat last week and had projectile vomiting within 5 minutes after receiving it. And they cut the dose down in half, and it vomited after about 5 minutes rather than, after 60 seconds. And they had to give a very, very low dose for the cat to tolerate it. I would say in general, that's probably the minority of the patients that I've seen who've had J upset with it. Maybe a small percentage that have some diarrhea with it, but most tend to tolerate it pretty well in my hands. And I have a lot of clients who say that the cats take it super easily. That one didn't want to stop it because they use it as a food topper, and they don't like the break because then their cat's being a bit pickier because they want the melligistat on top of it. But in my experience, I think most cats have tolerated it pretty well. But certainly the GI upset is probably the more common side effect I see, certainly even more than hypertension or seizures or anything else like that that's been tangentially associated with it.
Yeah, especially the cats that we know have comorbidities with underlying GI disease and whatnot. I think those are really challenging cases in general. And, how much of that is truly medication induced versus underlying disease process.
So, Dan, thanks for going over these. As an author of this paper, I did go over the data for the pilot study fairly extensively. And the vomiting, there was definitely more vomiting in the molidustat group compared to the placebo group. But when you look at the data, there were two cats who vomited daily and about 15 minutes after getting the pill or the medication, it's a liquid. Um, and then the other cats vomited, about as much as you would expect a cat with CKD. They vomit every now and then. So that definitely skewed the data, but I do think that there are cats out there that do have GI upset. And the ones who aren't eating as well, I do wonder if maybe they actually do have some nausea that isn't actually manifesting as vomiting. As far as the week off, the drug holiday, that is because the healthy cat responded phenomenally well to the drug and would actually become polycythemic if left on the drug. And the concern from the FDA was that if the owners didn't come in for rechecks, if they weren't following our instructions, which happens,
That happened. I had one last week. Owner
yeah.
did not fill the instructions, went up to 60% for its PCV.
Wow. So that break is to make sure that cats don't become polycythemic because that does have some downsides. But I think that in the study data, both the pilot study and the pivotal study, and what we've seen clinically in cats with CKD, it is not as effective as it is in healthy cats. And that's not surprising. But when you look at it on an individual cat basis in the CKD group, some really responded quite well. And when they went on that holiday, they wouldn't get started back until if they got to over to 45% and were stopped, then they wouldn't get started back again until I think it was 30%. Some of those cats could go for a month before they needed another round. But there were other cats that their PCV would drop during that week that they were off. You would lose all of the ground that you'd gained, start back at ground zero, build up for a month, stop, and that is a that cycle. I am hopeful will change if this drug goes from conditional approval to full approval. Um, but when I looked at cats who were on Darby, a third of those cats had significant other comorbidities that were inflammatory diseases that were impacting their ability to for erythropoiesis. So it totally, I can totally buy that some of these cats just have so many other things going on that they're not able to respond. Um, and as far as the group that dropped at that last data point, realized that was only 10 cats compared to 50 when they started. And so we had gotten down to so few cats in that group. And same thing for the pilot study, where at 21 days they had dropped down. It's because we were so many of the cats in the placebo group were getting lost because they were dying of anemia or they were dying of things that could have been. I mean, they came in to Kipnick and moribund. Um, Maybe it was their anemia, maybe it was a stroke, maybe it was their uremia, but it totally could have been their anemia.
And to follow up on Kathy's point too, because this is a question I get a lot, going back to the, well, for the CKD cats, why don't we just keep going? Like, let's not do the break because they're not acting like the healthy cats. And I just want to remind everyone that Varenzen CA1, the CA1 means conditional approval number 1. So this is the first conditional approval for the drug. It's technically possible for a drug to have multiple conditional approvals. So it might have one dosing for condition A, like anemia, or let's say they thought this drug worked great for trauma-related anemia, which doesn't make sense, but let's just say they did. That would be like conditional approval 2, CA2, and they could have different dosing strategies completely. But as required by the FDA, like we're not allowed to give the drug other than what it's labeled as for a conditionally approved drug. We don't have the freedom like we do for most other drugs to be able to give it off label and to use it at potentially different dosages than what was approved, or even certainly the drugs that aren't FDA approved that we use. We are required, because the whole point of conditional approval is that the FDA is saying, well, there's enough safety data that this is probably okay, and there's enough efficacy data to warrant a larger investigation, and we will allow the company to start producing it, and they have a 5-year window to start producing it, gather more data, and then submit that for final approval. But it's possible that final approval could be denied. It's not a guarantee, or it is accepted. And once it gets final approval, then it just becomes Varenzen. It's no longer Varenzen CA1. And then we would have the ability to dose it, even if it's still labeled as 28 days on, at least 7 days off. We could prescribe it off label as once daily continuously, but we're legally not allowed to do that right now. And I think that's a question I get a lot from colleagues. So not that I think the FDA is going to hunt you down, but it's just something that I just don't think people recognize that we have to stick with that dosing right now because of the conditional approval, because there are just so few drugs that we have that have conditional approval. So I think a lot of people are just not familiar with what that means and how that it restricts how we prescribe it right now. I think there are some cats that are good responders that might do better with like 3 milligrams per kilogram once a day rather than 5, and some cats might do better with 5 milligrams every other day. And there's probably a dozen dosing strategies that could be used that probably would be really effective, but we have to wait until it gets full approval before we really start messing around with those alternate protocols.
Is anybody using this more long term? I'm going to be honest with you. I have not used it past that 28-day mark. Typically, if I have these cats, then I'll talk to owners about Darby versus, continuing the molidustat. And, some of the owners are, coming up with the hyperexia, not eating as great, maybe some vomiting. So then we end up trialing Darby at that point.
I agree with you. I've moved away from using them as much. Like I feel like I use Darby a whole lot more. And for better or for worse, I think we were all really excited about administering an oral medication instead of injectable. But for so many of my CKD patients, another oral medication is more of a headache for them than a sub-Q medication. Um, So I feel like I'm using it less and less with that. And I just like the response that I see. I, I mean, obviously what you're seeing here, but just compared to Darby versus this, it's just I've moved away from using it a lot more.
Yeah, I think my experience is the exact opposite. I probably prescribe it for 80% of my CKD patients that need um, and medications for their anemia. So it's largely replaced Darby for how we manage anemia. And I would say the majority of cats are responders. Some of them are definitely lazy and require 2 or 3 cycles. And if they're tolerating the drug, and they don't get worse after the first cycle, even if they're not better, we keep stick it out. We'll go to cycle number 2, we'll go to cycle number 3, and we do often see that they have gotten better. There are those that subset that don't tolerate from a GI perspective, but in my hands, I would say that that's probably no more than maybe 10% or so. The majority of my patients seemingly dig it, which I don't deserve any credit for it. I just think that's maybe just luck. But we've actually been prescribing far, far less Darby because we've seen many of these cats do well. I mean, some of our cats have responded great, and after the first cycle, they've gone from 22 to 48 after the first cycle, and they kind of act like some of those cats that are the healthy cats as well too. So yeah, we've actually been pretty happy with it. We still use it a ton. I think am burnt by giving Darby for 2 or 3 months and still not seeing as great of responses and burning through all the cost that go along with that as well too. And not that that's the majority of patients that respond that way, but it's certainly frustrating to go through the injectable, which I mean for us it's about $500 a bottle. So for most cats, that's like 5 kilo cat dosing at 1 mic per kg per week. That's like just over a month's worth. So certainly cheaper to use molidustat than Darby. And I guess it all comes down to if they respond and if you're able to taper Darby down to every other week or something like that, then the price point certainly might shift. But we've been using a lot of it. We've been pretty happy with its response overall.
Yeah, JD, my experiences are similar where I pretty much use it exclusively now. And almost in cats, I actually can't remember the last cat I prescribed Darby to be honest. I actually was like disappointed the other day when I had to prescribe Darby for a dog and I had to re-look up the dose because it had been so long. I'm embarrassed to say. But in one of the I do a lot of subs here, and so one of the things I thought about because I've seen it similarly where it takes several cycles, and I part of me for me I was wondering if there was just a lot of disease in these cats. They come into the hospital, they have a ton of blood draws, when they come in for a sub. They already have CKD, and so they also, I'm sure have some inflammatory component. They have their underlying CKD. They've had a lot of blood sampling. And so my thought previously, have used it a lot more in having more experience with that was that it took a couple cycles too, just because it just takes time for these cats to regenerate, and probably the inflammatory component was more than I could appreciate. And some of these cats are infected when we place their subs. So that was kind of my thought, but I don't know if in the pure CKDs who aren't having an acute insult, if that's similar, if you're finding that as well, JD.
Totally. I think just like we see with Darby, if they get in an inflammatory process concurrently, it either minimizes its efficacy or can wipe it out. I've had cats
Yeah.
that have done great. They're cruising. They have a hematocrit in the 40s with Forensin. Then they get an episode of Pylo, and then they bottom out and they're back in the 20s. And I think it's probably all just those inflammatory cytokines that
Yeah.
we often blame for anemia, chronic disease that are just minimizing the efficacy. And I think that that suppression is not necessarily better or worse with either Darby or molidustat. I definitely see it with both.
Yeah. And I'm sorry if I missed this. I had an emergency consult during your presentation, Dan. And thanks for doing this, by the way. Did you guys talk about iron supplementation at all? And what people are doing as far as, are you supplementing iron in any standard protocol?
Yeah, I personally give iron whenever I'm starting either Darby or molidustat. Just given that measuring iron is a pain, and I don't do it for all my patients, but it's easy enough just to give them a dose of iron.
Yeah, I've been using a lot of this as well in cats and have also largely moved away from Darby and have been very happy with the results. I had one cat that kind of went from PCV or hematocrit, I can't remember, in the 20s to 45% after one cycle, and it kind of stayed that high for a few months before needing a second cycle. But I've also routinely been doing iron for all the cats that I started on. And I think maybe one or two when I first started using it, I hadn't done it with, and I wasn't as happy with their initial response. But obviously, that's not a statistically significant study by any means. But ever since then, I've just been doing it routinely.
Yeah, I would say we're pretty mixed. If I know they're anemic coming to me on their consult labs that I get, and I'm going to start molidustat as part of the appointment, then I'll give them iron that day. But if I'm rechecking a patient and I get the labs back the next day and they're anemic and I'm going to start molidustat, then I just prescribe molidustat. I don't have them come back in for an iron injection. And I can't say there's been an obvious signal to me for patients responding or not. And even when I do give it, because they come in and I recognize they're anemic and I'm prescribing it as part of the visit, then usually my protocol is usually I just do it at that first visit. And then if they fail to respond for molidustat after that first cycle or for darbepoetin after the first month, then I'll probably consider redosing it. But otherwise, I don't generally give it beyond that first one. And like Dan, you pointed out, like I'm not routinely measuring iron panels, but I think Kathy's data and some of others have suggested, there's just probably some trapping of iron and it's not as readily available. So maybe these cats would do better, but with it, but I've certainly seen plenty of cats still respond who've never had any iron. So I'm not bringing them back to give them an iron injection once I see their labs and I'm, putting a prescription in for them to get molidustat from Chewy or something like that. We're just kind of going to ride it from there. And I can't say that I've obviously felt that that's caused them to not respond.
While we're talking about the iron supplementation, I want to see everybody's opinion about the B12 injection because it's not part of my protocol. But then some internists I work with, they feel strongly about giving weekly B12 injection, and I'm just like, okay, then go ahead and do it, but I don't know how everybody feels about it.
Are you saying B12 injections with like Darby or Varenzen?
Yeah, yes.
I'll let others chime in. I have never seen any data for that.
So the B vitamins are necessary for erythropoiesis, and being water soluble, they can be lost due to polyuria. And in people, there is data that their B vitamin levels are a little below normal. It's been so long since I've looked at the data, I can't tell you specifically which B vitamins, but it's not just B12. But and I am as old as the hills, and I predate even Epogen as a treatment where all we had was, what's the anabolic steroid, Winstrol, and B vitamins to treat anemia of CKD. And they're not going to do that much. Now, they're very safe. So if you're giving just a little extra um, tweak, like I wouldn't even call it a tweak. I would call it a mini tweak by giving the B vitamins. You're not going to cause any harm, but it is not part of my protocol to routinely give B vitamins to these animals.
Thank
Yeah,
you.
I'm with you, Kathy. I think, there is probably the more obvious connection of B12 deficiency causing pernicious anemia, and it's a macrocytic non-regenerative anemia. There are, I think, a few isolated case reports of like puppies with that. Um, I mean, I think these cats, if they have B12 deficiencies, is because of their underlying enteropathy or small cell lymphoma, rather than relating to their kidneys. Maybe a combination of both. It's not something that I do. I also feel the same as Kathy. Like, if you want to give it and they don't need it, you just made their pee slightly more expensive for the next couple days, and that's probably about it. But it's probably a very safe thing. But I don't include it as my routine approach to treating anemia.
Yeah, here at Texas A&M too, we have the GI lab. So I see a lot of B12 panel GI panels on these patients because it's really, really accessible. And there's a lot of studies that are done here. And so there's always, if there's extra blood, I mean, this is completely anecdotal, but I do not think the cats that have primary CKD and do not have a chronic enteropathy, these patients are not B12 deficient, at least what we can tell. I mean, we're not running MMAs on them. So as far as intracellular stores and what they're utilizing, I can't say that. But as far as total B12, I see a lot of B12s run for a variety of reasons. And the chronic kidney cases, and I'm doing some collaborative work with the GI lab on some other stuff. And so I see these panels and they are not historically B12 deficient. So I'm not saying it's right or wrong, but just I can say that at least I see these B12s and folates on a lot of these guys, and they are typically quite normal.
As an internist, I do want to chime in for the people who have criticalist training, and that is that these stage 2 CKD cats who are losing weight probably also have an undiagnosed chronic enteropathy. Those are both very common diseases in older cats. So when I was seeing a lot of cats with CKD that were being referred in for weight loss, a lot of them needed extra workup and extra attention to their gut. So don't ignore that part of the cat.
I would agree with that. I feel like 60 to 70% of the cases that come in like that with a lower stage of chronic kidney disease and they're losing weight, I'm usually on a GI hunt, and I didn't realize I was going to be doing a lot of GI disease when I was doing kidney disease, but here we are.
Yeah, or hyperthyroidism, right?
Oh yeah, that too. Yeah.
And Jenna, I do agree that the cats who just have CKD and no chronic enteropathy, their B12s, I can totally buy that their B12s would be normal. I wouldn't expect them to be abnormal.
I think it'll be interesting. I was just kind of getting into the weeds with some of these other articles, and it seems like even in some of the hemodialysis patients in people that they use different dosages of the HIF stabilizers. And so I'm curious what some of the dosing regimens are going to be in our patients, if they're going to change at all, kind of alluding to what JD had mentioned previously. And I think that's definitely down the pike, and really something that I'm interested to see. Okay, who's going to respond to a lower dose and who's not? I think there's a lot of comorbidities that we see in our patients, and what can we get away with as far as the quote unquote lowest effective dose possible in some of these patients. I think that's all I've got. Anybody else have anything else to add? Perfect. I'll see y'all next time. I
Thanks,
appreciate
Dan.
you guys attending. Thanks a lot.
Yeah, really appreciate it. Awesome work.
Thanks,
Thank
Steve.
you.
Thanks,
Thank you,
Dan.
Dan.
Bye.
Thank you.